Hi all, welcome back to my channel. We are going to go over an extremely important section of the ANCC PMHNP boards today. So I'm sure you've heard either through school or just socials or whatever it may be about these dopamine pathways, but I am here to tell you that it is just as important as everybody says, because there are so many questions on the boards about this, and it is important to understand because it helps with pharmacology down the road. Don't let that freak you out though, because truly once you get the grasp of it, it's not too bad. We're going to go through a very systematic approach to this. This was the best way I learned it, just because I had to kind of wrap my head around stuff that doesn't necessarily make sense when you're reading it. But the more you watch videos, the more you look at this, the more it will come together. And if you think about pharmacology and what medications do, when you think of these dopamine pathways, you'll understand it. It will make sense. So let's get into it here. Our dopamine pathways. First, we just need to know that there are two important receptors here. So these are going to be dopamine receptors. They're going to be known as D2 and D4. D2 and D4. D2 is going to be the most important one. Another important piece, again, this is kind of just like the foundation part. We are going to remember that dopamine is known as an excitatory neurotransmitter. And if you think about this, think psychosis, excitatory. So if we're having a lot of dopamine, we get that excitatory psychosis, hallucinations, delusions, that kind of thing. And that's how I remembered that, the excitatory thing, psychosis. It's an excitatory neurotransmitter. Second, again, a foundational part that will help you with the next slides I go into. So when you think of dopamine, think of Parkinson's, think of schizophrenia, think of addiction. If you remember from my last video, I said I remembered it by DAMPA. So DA for dopamine, and then the motivation, memory, and then PA was for the like the grandpa that I remembered, and that was for addiction and psychosis in there. So that's how I remember dopamine. With this, so think Parkinson's again. So in Parkinson's treatment, so if we're giving a medication for Parkinson's, we are going to be blocking or stimulating D2. So if you think about it, in Parkinson's, what's our main symptom we have? Movement issues. So when we have movement issues, that means we do not have enough dopamine. So I need you to remember that. Movement issues equals not enough dopamine. So in Parkinson's treatment, we're trying to fix that. We are trying to make those movements settle down. So we are going to stimulate the dopamine by giving a dopamine agonist. And remember, agonist means it's going to do the same thing as what the neurotransmitter does. So we're giving dopamine agonist to get dopamine levels built up to reduce the shakiness. Opposite of this, think of schizophrenia. So in schizophrenia, remember what I just said a few minutes ago. Dopamine, excitatory, psychosis. If there's a lot of dopamine, we're going to get the kind of positive symptoms that we think of in schizophrenia. So we're going to get those hallucinations. We're going to get those delusions because there is too much dopamine when we have schizophrenia. So if you think about Parkinson's versus schizophrenia, they're a teeter-totter. Parkinson's, not enough. Schizophrenia, too much. So in schizophrenia, our antipsychotics are going to what? Block or stimulate dopamine? Block. We want to block that dopamine because we are having too much. We're getting those positive symptoms, hallucinations, delusions, all of that. So that's a good foundation to remember. So remember, dopamine too low, we get movement issues. Dopamine too high, we get hallucinations, delusions, all of that good stuff. Okay, last bullet point on here. This is just a quick rundown. When we think of dopamine pathways, there are 4 that you need to know for this exam. There are 4 total, but there are 4 that you need to know all of these and how they work. So 1, mesocortical. 2, mesolimbic. 3, nigrostriatal. 4, tuberofundibular. So you need to know all of those, and we're going to get into that in the further slide here. So number 1, mesocortical. When you think mesocortical, cortical you can think of as like thoughts, mood. This is how I remember it. Cortical being that last word there. So when you think of mesocortical, you're going to automatically think the negative signs and symptoms of schizophrenia. So what are negative signs and symptoms of schizophrenia? Right, we're going to get the depression, anhedonia, that flat affect, low mood, lack of attention, lack of focus, all of that. Those are negative symptoms. So when you think mesocortical, think cortical thinking, all of that negative. So for schizophrenia specifically, if there is a decrease in dopamine here, we're going to think of those negative symptoms. Because remember, if we had too much dopamine, we'd get the positive symptoms, we'd get the positive symptoms, delusions, hallucinations, all of that. So you're going to think the exact opposite here. Mesocortical, decrease of dopamine, we're going to have negative symptoms in schizophrenia. All right, next part here. Mesolimbic. Don't get these two confused. They're different, similar name, but different. Mesolimbic, you're going to think more of like emotions. So automatically, when you see mesolimbic, you're going to think positive signs and symptoms. So if there is something in mesolimbic with schizophrenia specifically, there's an increase. If something is causing an increase in dopamine here, what do we think of when there's an increase in dopamine? Remember, increase of dopamine, positive signs and symptoms, delusions, hallucinations. Too much dopamine, we are getting positive symptoms. So that is very important for the exam purposes. Mesocortical, think negative signs and symptoms of schizophrenia. You're going to think if there is a decrease in dopamine here, we've got that low mood, that anhedonia, that lack of focus. We've got the flat affect. Mesolimbic, we're thinking emotions. We're thinking the hyper. We got too much dopamine. We're thinking delusions, hallucinations, positive signs and symptoms for that mesolimbic. Let's go on to the next 2. So for our nigrostriatal, as soon as you see the word, you need to think movement. Nigrostriatal is the movement center. You automatically think EPS or TD when you see nigrostriatal. So in this area, if you were to think about kind of what I said at the beginning of this video, what do you think would cause movement issues? Would it be an increase or a decrease of dopamine? Think back to Parkinson's and what Parkinson's treatment does. So Parkinson's is a movement. We have movement disorder there. And when we treat Parkinson's, we give a dopamine agonist. So we're building dopamine up. So what does that mean then? If we're in the nigrostriatal area and there is a decrease in dopamine here, what are we thinking with decrease in dopamine? We're thinking movement concerns, and we're thinking like that negative, the signs and symptoms of schizophrenia there. So too little of dopamine, and we're going to see movement issues in the nigrostriatal area. So think Parkinson's, EPS, and TD if you're seeing a decrease in dopamine in the nigrostriatal area. All right, next on for the tuberofundibular. When you think of this, and I have kind of a messed up way to think about it, and I will tell you that in a minute. Tuberofundibular, you're automatically, as soon as you see the word, you're going to think prolactin, gynecomastia. Those are the 2 things you're going to think of because this area works on that. So A little bit of background with this. This area anatomically is near the pituitary gland. The pituitary gland controls hormones. So if we have a decrease in our dopamine in this area, this is going to cause an increase in prolactin. So if you think back to our psychopharm classes, and we're always testing a prolactin level for anybody that is on antipsychotics, this is why right here. Because our antipsychotics are working on dopamine, decreasing it so that we can get rid of those positive signs and symptoms of schizophrenia, but it is also decreasing the dopamine in the tuberofundibular area, which causes that increase in prolactin. So this is how I remember it. Kind of messed up. Don't come at me. Tuberofundibular, I think of tube, the tube beginning, tube socks, which makes me think of boobs. There's like a big joke. I breastfed my baby, so there's where people say that if you breastfeed your baby, you have tube socks as boobs. This is how I remember it. It worked. I passed my exam. So think tuberofundibular, tube socks, boobs, prolactin, gynecomastia, and increased prolactin levels. So that's the way I do it there. Hopefully that helps you. I did not type that on here as a test tip because I didn't want people coming at me for it, but it does help. So that is the main rundown here. That is the foundation. That is what you need to know. And again, like all of my other videos, we're going to build on this. So let's jump into the last slide. And then later on in the week, I'll have a little bit more build on this regarding psychopharmacology with it. But here's a brief rundown of psychopharm with this. So schizophrenia and dopamine pathways. This is what you're going to see on boards mainly. You will see some of the Parkinson's like I talked about, but they really want to know your understanding of schizophrenia, how antipsychotics work, and the dopamine pathways. So all three of those things connected. So this page here will be a good one to screenshot because this is what you're going to get tested on. So mesolimbic, what do we think of? That emotional area. So if we have dopamine that is increased in this area, remember, what do we have? An increase in positive symptoms. Your typical, what you would think of with schizophrenia. You're going to have like the psychosis, the hallucinations, the delusions. That is the mesolimbic area because it has an increase in dopamine. Mesocortical. What do we think of with mesocortical? We think of negative signs and symptoms. Our dopamine is decreased in this area, causing the negative signs and symptoms. Think depression, anhedonia, flat affect, the lack of focus. Think of that when you think mesocortical, like brain, mesocortical. Decreased dopamine here, negative signs and symptoms. Nigrostriatal, remember, what's the first thing we think of? Movement. Nigrostriatal, you see that, you think movement. Dopamine helps control the movements in this area in schizophrenia. So if you're at a normal level of dopamine in the nigrostriatal area, you're not going to see EPS or TD. But if we start an antipsychotic and we decrease the dopamine in this area, what's going to happen? Remember what a decrease in dopamine does? Movement concerns, EPS, TD, Parkinson's. So decreased dopamine in the nigrostriatal, you're going to see movement concerns. Tuberofundibular. So remember my little way to remember this. Tuberofundibular, tube socks, boobs, prolactin, gynecomastia. That is how I remember it. Dopamine helps control the prolactin levels in this area. So if you start an antipsychotic, you're going to be decreasing the dopamine all around. It's going to hit this tuberofundibular area. Your dopamine is decreasing, which means your prolactin levels are going up. You can have gynecomastia, increased prolactin levels. So tuberofundibular, tube socks, prolactin. That's how I remember it. All right, I thought that was the last slide. I lied. This is the last one. It's kind of what I just went over. So dopamine pathways and antipsychotics. We kind of just discussed this. So in summary, our antipsychotics that we give patients with schizophrenia, they're going to block D2 receptors. Remember, block. So we're decreasing. They are dopamine antagonists, which means they are blocking dopamine because there's too much dopamine when we have schizophrenia. That's why we have positive symptoms. So antipsychotics are going to block dopamine. So anytime one is used, think dopamine is going to be decreased in all 4 of those dopamine pathways. So what happens when dopamine is decreased in all 4 of these pathways? We just went over it. So mesolimbic, what do we think of? Positive signs and symptoms. So the typical things we think of with schizophrenia. So if we have too much dopamine here, hallucinations, delusions, that's the mesolimbic area with too much dopamine. If we give an antipsychotic, we decrease that dopamine. So then we decrease our positive symptoms, which is the goal of treating with an antipsychotic in schizophrenia. Mesocortical, think brain, think negative symptoms, negative schizophrenia symptoms. So if we're using an antipsychotic, is it decreasing the dopamine? Yes, it's decreasing. So unfortunately, when we use antipsychotics, sometimes we can actually increase their negative symptoms because we're further decreasing the dopamine in this area, which may already be decreased in schizophrenia in the mesocortical area. Nigrostriatal, what do we think of? Movement. So if we have normal dopamine levels here, we don't have any movement concerns. If we give an antipsychotic, what happens? We decrease the dopamine. With a decrease in dopamine, we get movement issues. So we can get abnormal movements with antipsychotic use. Tuberofundibular, tube socks, boobs. Think of prolactin, gynecomastia. If we're giving an antipsychotic, we're decreasing the dopamine in the tuberofundibular area, which is going to further increase prolactin levels, could cause gynecomastia. So that's the breakdown of that. What I want you to remember, I feel like nigrostriatal and tuberofundibular are pretty easy. That mesolimbic and mesocortical is what trips people up. Remember, mesolimbic, think positive signs and symptoms of schizophrenia. There's too much dopamine here. In the mesolimbic area, too much dopamine. Mesocortical, we do not have enough dopamine in the mesocortical area. That is why we have those negative signs and symptoms of schizophrenia. So unfortunately, when we treat with an antipsychotic, we're going to further increase those negative signs and symptoms because we're further decreasing the dopamine in this area. So off to the side here, you'll see we have our typicals, our first generation. You're going to want to remember this. So our first generation of antipsychotics are going to block strictly the D2 receptors in all of the dopamine pathways. But I want you to remember, if you're blocking the dopamine in these areas, the mesolimbic, that is our goal, that's what we want to do first, it's also going to hit the other dopamine pathways as well, which can cause issues that we just discussed. Moving on to our atypicals, which are used a little bit more frequently now, and you'll see why here in a minute. Our atypicals, also known as second generation, they block both D2 receptors, also work on 5-HT. What is 5-HT? Serotonin. So these ones we use because then they won't work on those negative signs and symptoms of schizophrenia so much. Because remember I said the mesocortical area already has a decrease in dopamine in schizophrenia, which is causing the negative signs and symptoms. We don't want to hit that any further than what we have to, and like the typicals are going to hit it and decrease that dopamine further. Our atypicals don't hit that as much because they also work on serotonin, not just D2. So this gives us a decreased risk of the movement issues. It gives us a decreased risk of making those negative signs and symptoms worse. So when you think of atypicals, you're not going to think of like the movement concerns that you think of with the typicals. You're going to think of metabolic concerns, which we'll get into in another video. But those ones are going to be your drug of choice right now because you're not going to make the negative signs and symptoms of schizophrenia worse by using those, because we work on serotonin as well. So this was a brief video. This is the foundation. Listen to it over and over and over. Use little tips and tricks to make sense of this. Once you get this foundation, it's a piece of cake. Once you get this stuff, pharmacology is going to make so much more sense. You're going to understand why you want to use what medication and when. This is the big piece here. It's so important that you understand this. If you have any questions, I always put my email below. Remember, I own a farm, I have a baby, I work full time, I have a second job now. So all of things, if I don't get in touch with you right away, don't be mad at me, and don't come at me about the tube sock thing. It's funny. So have a good one. I'll see you next time.